That's it, we're live now.
Okay, well, afternoon everyone. I think I would hope everyone's got a clear signal. My name's Steve Hodgson. I'm an orthopaedic hand surgeon from Bolton. I've played a part in leading the BSSH efforts in supporting the development of hand surgery in low to middle income countries over the last 10 years. And it's really good to be able to welcome you to this webinar this afternoon. I want the two themes of the webinar to be about fellowship and wisdom. Fellowship is a form of friendship, but with a common purpose, and the purpose that we're here for, working with the West African College of Surgeons, is to support the development of hand surgery in West Africa. We've got Phalangeal who's going to speak after me, and the effort started really with a very productive visit to Abuja, Nigeria in February this year, where we were very privileged to deliver a 2-day educational program and take a small part in the West African College of Surgeons annual meeting. And that led to us working on a memorandum of understanding where we're going to provide a 5-year educational program and have an ambition, quite a high ambition, but to develop a certificate in hand surgery fit for postgraduates in Africa, designed by them and in conjunction with the University of Manchester. So this is a small step along the way towards that fellowship. The wisdom part comes from gaining different perspectives. We all treat hand fractures the way we've been brought up to treat them, but real wisdom comes from hearing different perspectives, and the program's been designed to give those perspectives, how hand fractures are treated in a high-income country such as the UK and how they're treated in West Africa. They're the same conditions, same evidence. We all have the same duty to provide the best possible outcome. And I think we will learn an awful lot this afternoon. In the UK, we're very fortunate to, that healthcare is free to anyone who presents with a hand fracture. They also tend to present on day 1 after the injury. And we have very well-equipped hospitals to treat them, and a really good team behind the surgeons, working with the surgeons. In the UK, you're not a proper hand surgeon unless you've got a really good hand therapist to help manage your patients. So I'd like to introduce the 2 UK speakers. We've got Zaf Nakvi, who's a surgeon from Salford Royal Foundation Trust. He's been a council member of British Society for Surgery of the Hand. For several years was social media lead and moved things forward a lot in that area. He is head of department at Salford Royal Foundation Trust, which is the major trauma centre for Greater Manchester. So it comes with a wealth of experience of hand trauma. And then we've got Deb Stanton, who is a key member of the British Association of Hand Therapists. Does an awful lot of educational work and overseas work. So thank you both for stepping forward for this. So if we can hand over to Phalangeal now to give the West African College of Surgeons perspective.
Hello everybody, welcome to today's webinar on hand fracture management, which is jointly coordinated with BSSH and West Africa College of Surgeons. Steve has introduced the 2 UK speakers. We have Kemi Ayode, the plastic surgeon from Nigeria, who is going to be speaking on hand fracture management, the West Africa perspective. She's an experienced plastic surgeon. She's also a BFirst fellow, and she's going to give us more insight to our experience, despite the shortcomings we have as per funding for care in the middle/low income society. We are still able to manage quite a lot of cases, even though they present late. I'd like to thank everybody for joining us. And this meeting is being recorded, and would like to hear from you as per questions and answers. So you could pose questions in the Q&A. Thank you very much.
So Zaf's going to start. Well, whilst he's loading his presentation, as like he says, please do post questions during the talks. I will ask the speakers a selection of questions. The first half of this program is the 3 set-piece presentations, and then we've got some interesting cases to discuss where we're very keen to get your perspectives on management of those cases. So over to you, Zaf.
Thank you, Stephen. Thank you, Falaki, as well. As Steve has said, my name is Zaf Nakwi. I'm speaking from Manchester, and I'm going to share my screen now. Hopefully you can all see that. Can you confirm that you can see the slides, Steve?
Yes, yes.
Okay, okay. So, as Steve says, I work at Salford Royal Foundation Trust, which is one of the big teaching hospitals here in Manchester, and I work also with the BSSH. So it's lovely being here with you all. And Steve asked me to give a talk on the principles of hand fracture management, just for 15 minutes, with reference to operative intervention, and where there may be some contrast with the techniques in West Africa, potential contrast, because I'm not fully aware, and I'm here to learn from all the panel members and all the audience, and I hope to gain quite a bit from this afternoon session. So the principles of managing hand fracture are quite, I would imagine, are universal wherever we are in the world. And these are the principles that are important to me. The goal really for me is that we restore hand function, and it is as simple as that. We need to find a way following the injury to restore hand function. And this can be, and often is, different to having a perfect looking x-ray at the end of a patient's treatment. The second rule for me when it comes to hand trauma is to understand the soft tissues, because my education and upbringing and training when managing hand trauma is that the fracture is actually a secondary thing to the soft tissue. So it's a soft tissue injury always first, with a break in the bone. Thirdly, when managing any fracture, we need to consider how we manage fractures, which is basically to reduce the fracture if it's not reduced, find a way to hold it there, and particularly for hands, rehabilitate with speed. And that brings us on to the fourth point. Hand injuries have a very narrow treatment window, and delayed presentations of hand injuries, we will all know, presents a particular problem because of stiffness. My fifth rule for me is that any hand injury requires a multidisciplinary approach, and you will be aware that hand surgery as a specialty actually arose due to the multidisciplinary need for managing hand injuries within the First and Second World War. The understanding came that we needed plastic surgeons, orthopedic surgeons, general surgeons, and of course therapists to come together to manage a hand, and then hand surgery evolved as a discipline. So I'm going to talk about some operative things, but the default really for most fractures that we manage in the hand is non-operative treatment, because most are stable and require protective mobilization. Oh, sorry, I think, let me try and start again. Sorry, Steve, about that. So I'm the wrong way around. I just want to say a few things about Manchester, Manchester, you will know, most of you in West Africa, where Manchester is. We don't really argue much about fractures in Manchester. We argue about what is the best football team. And I won't tell you which football team I support, but I'd like to just point out here that only one of the current football teams in Manchester has West African players in it, and that is Manchester United. Manchester City currently have no West African players. So I'm sure you'll all know which team to support in Manchester. Okay. The other thing I want to say is that hand fractures are little injuries, but actually they cause big problems. And two very famous surgeons, John Charnley and Alfred Swanson, have commented upon this very fact, that that a hand fracture can be complicated by deformity due to treatment, stiffness from over-treatment, and both stiffness and deformity from poor treatment. So commonly managed non-operative injuries in the UK will be fifth metacarpal fractures, will be isolated metacarpal shaft fractures, will be undisplaced or well-reduced mallet fractures, and volar plate injuries, as well as quite often pediatric injuries. Operative intervention, we've talked about reduce, hold, move. And when I'm thinking about how to intervene operatively, if need be, I'm thinking all the time about the impact of the metalwork versus prolonged immobilization. So will my metalwork make a difference to holding the fracture and being able to move the fracture early? That's the key question I have to answer. Secondarily, I'm thinking about the position of scars, where I'm going to put the scars and the impact that will have on the soft tissues, the nerves, the tendons and the skin. And then I'm thinking about the vascularity. If I put too much metalwork in and strip the bone, will there be a potential for non-union? And of course, there's technical challenges, and we'll talk about those. But the key thing is that the metalwork may be very simple, such as a K-wire, but may be technically very demanding. So here's an example of a type of fracture that I would be considering potentially operative intervention, because it's an articular type fracture. We're going to start with a metacarpal head, and it's quite a sizable portion of the metacarpal head. And when I look at it clinically, there is evidence of malrotation. So I'm thinking, how do I need to manage such an injury by, at a joint where I can get early mobilization, which is crucial. However, placing metalwork across a joint and interfering with the capsule and the soft tissues around the joint is a real problem, because whilst I can get a great looking x-ray, that joint may not move again. And so one of the solutions we have is headless screws, which can go deep to the cartilage. Although some of the cartilage is damaged, by inserting the screw, we can get early mobilization. When it comes to metacarpal shaft fractures, most shaft fractures will be managed conservatively, non-operatively, but indications for operative management would include rotational deformity, unacceptable volar angulation, such as over 40 to 50 degrees of volar angulation, severe shortening, or when there's soft tissue injuries. And the mainstay of treatment operatively is K-wiring. You can see in the top right of the screen wires going transversely across from the fifth into the fourth. And this is probably one of the most easiest methods of using wires for a fifth metacarpal fracture. There are technical considerations. They're very small bones and they're curved, and the K-wires can bounce off also volar as you K-wire. And I think K-wiring actually is the most technically demanding to get right first time. There are many tips and tricks, perhaps for another talk. We need to use the right size K-wire. Small K-wires, 1.2 millimeters, I would use at metacarpal level. Are the techniques in K-wire, such as cross K-wires here or going through the joint. And again, these are can be technically demanding, and we have to really consider whether what we're trying to achieve is worth the potential damage to the soft tissues and restriction to the capsule. If I'm thinking about opening and reducing, such as when using metalwork, such as plates and screws, then we need to think about placing our incisions. I try and avoid placing incisions directly over the metacarpal so that we do not have scar over the extensor tendon. And we've got to watch out for our dorsal nerves. When fixing a metacarpal shaft, I will try and avoid using a plate if I can. And so I will try, if amenable, if the fracture is amenable, to use lag screw techniques. You can see the technique here where we are reducing the fracture and holding it with a lag screw technique. Now, this is only a useful technique if we actually get a very good reduction and a good hold across the fracture, so good reduction of the fracture. Otherwise, it's not an effective method. Metacarpal shaft using plates, the indications would be considerable comminution, significant shortening and malrotation, good soft tissues, so we don't want big defects over the metalwork. And again, we can use a combination of plate and screws. Where there's significant soft tissue problems, we will then move to external fixators. At the base of the metacarpals and the CMCJ, the 4th and 5th CMCJ is a particular problem, and we see quite commonly here in the UK. Often they've either delayed presentations or missed subluxations or dislocation of the CMCJ, where it can sit, the metacarpals can sit dorsally. And so I have a very low threshold for these patients to reduce by distracting the little finger, as you can see in the bottom right image, and placing K-wires across both into the 4th metacarpal and into the hamate. And the key here is perhaps not so much the fracture, which you can see around here, but actually I'm looking at the joint line. Is the joint line good? Delayed presentation or dislocation, subluxation of this injury will lead to arthritis and pain, and it's very difficult to then manage that situation. When it comes to the thumb, we have a unique situation compared to the other CMCJs. The thumb has a number of deforming forces, as you can see, with the very strong adductor muscle which pulls distally, and therefore the base of the metacarpal will be abducted and move away. And so whilst you can see on this x-ray here a Bennett's fracture, it would appear that the two bony fragments are pretty close to each other. I have a low threshold there to intervene to try and reduce this because of the deforming forces. And of course, this is an intra-articular injury. We want to get the articular surface as close as possible. With comminuted fractures at the base here, you can see like a Rolando fracture here. Again, we would be plating and using screws here to primarily deal with the articular surface. In fractures where the articular surface is not involved, we can be a bit more generous in terms of being not as accurate, and we could allow a little bit of healing with the bone with the fracture not in an ideal position due to the web space that we have at the thumb. And so these are some of the techniques. I will prefer to use K-wires for a Bennett's fracture because there's less soft tissue stripping there, and you can get a good result. In Rolando fractures, where there's significant comminution at the base, then we use metalwork and screws, and often these will have to be removed at a later stage if there's significant soft tissue encroachment. You can use K-wires, which in the bottom picture we can see K-wires going across here for a multifragmentary fracture. But again, these are technically demanding procedures, and we have to be careful that the K-wires themselves are not causing too much in the way of damage or distraction of the fracture. And of course, the K-wires which are not buried are a source of infection if left in too long. So these are problems when using a K-wire for us to consider. Moving on to the phalanges of the fingers now. The distal phalanx is often managed conservatively. When I have a tuft fracture, I'm thinking mainly about soft tissues as opposed to the bone. The bone usually will heal unless there's significant displacement, which there usually isn't. So my attention is really at the nail bed and the nail matrix. When it comes to shaft fractures of the distal phalanx, again, often managed conservatively. If there's gross displacement, then I would use a single K-wire to try and realign that bone. The only significant operative intervention would be around fractures such as this, where in fact the flexor tendon, the FDP, has avulsed, and we need to get that back to get to restore function. And mallet fractures, as you can see here, are usually managed conservatively. The key here is to look for this volar aspect of the distal phalanx and whether there's been too much subluxation. And usually, conservatively, these can be managed conservatively without too much in the way of subluxation there. Moving on to the middle and the proximal phalanxes, this is where there's real debate, and there are so many different ways of managing these injuries. Multiple factors really will influence the outcome for these bones. Whether the patient can tolerate splintage, whether they what the fracture pattern is the fracture stable or not, and when the patient presented in terms of delay in presentation, and how long we will need to immobilize them, because immobilizing in a certain position for a long period of time whilst the bone is reduced will not result in a good outcome, because we'll end up with stiff. So fractures where I would be intervening operatively, where I have a low threshold, articular fractures around condyles. You can see here the ligamentous pull at a condyle will keep that fracture displaced, and although the DIPJ is a relatively easier joint to tolerate in terms of displacement, this is not the case in the PIPJ. So for these fractures, which are quite unstable, I would have a low threshold to come in dorsally, as you can see here on the PIPJ, and try and get an accurate reduction and fixation. And the fixation has to be spot on in terms of reducing that articular surface, but also in terms of the metalwork load. We can only use very small screws, and often K-wires are sufficient as well, as you can see in the picture here. A good way to reduce these fractures is to use closed reduction with little clamps there. At the base of the phalanx, often again managed conservatively, but there are some indications if there is a grossly unstable joint, and sometimes fragments such as this can lead to quite a bit of instability. These can be reduced and fixed from the volar approach through the A1 pulley. But again, I have a high threshold for this. I would try and manage this with splintage if possible, with buddy strapping, and maybe we'll discuss that later on in the program. When it comes to the base of a T-shaped fracture, where there's you can see here axial load and multi-fragments, again, this is a very difficult area, because to try and achieve a good reduction may require a plate and screws, and we do have the facility of very small plates, good quality locking plates and screws, but I have a lot of hesitation here, because the metalwork load does interfere with the capsule, and so although we can get a great looking x-ray often, we may not get a joint that moves again, and we defeat the object of what we're trying to achieve. K-wires, again, also possible, but we have to consider how much of that capsule is being tented and tethered when we try and use this method of treatment. When it comes to shaft fractures, again, a great amount of debate. I would intervene if there's instability following an attempted reduction, and in unstable fractures, we can discuss. But here you can see there's rotation here, where the bone has rotated 90 degrees of the proximal phalanx in the shaft here, we've got a significant deforming force of the flexor tendons here in this transverse fracture. And so the geometry of the fracture may well help us decide how to manage this, and we'll have some case discussions later. The mainstay, I would say, for middle and proximal phalangeal shaft fractures is to try and manage them conservatively, reduce, hold in a safe position. I imagine we'll discuss this later. When using metalwork or operative techniques for these fractures, again, K-wires are useful. This is technically demanding. You have a very small bone, which is of a very set shape, being circular, oblong. K-wires can bounce off multiple times off these bones, and if you multiply pass your K-wire, then you're damaging soft tissues, you're damaging the capsule, and you're damaging the bone, and potentially you could cause non-union and distraction of the fracture. So this requires this is a steep learning curve. Another way of using K-wires for fractures such as this oblique fracture is to go across, and this is easier to do and will allow some movement as well, both the joints above and below. If we need to go on and do either screws or plates, then there is a consideration of how to get to the bone. You can either go dorsally or mid-axially. The dorsal approach is my preferred approach. We just need to think about tendons, because the extensor tendons will scar, and this is where our hand therapy is crucial. But we have good access to the bone this way, and we can go straight down the tendon, and that will suture quite well. But early mobilization is required, and therefore we need good reduction of the bone and good hold, because otherwise there's no point fixing the bone and then immobilizing the finger in plaster because the fixation is loose, for example. The alternative is a mid-axial approach, and in this approach you need to be very mindful of the neurovascular bundle, and you can hook up the lateral band to access your fracture, as you can see here. And so indications here, so unstable fractures, long spiral fractures, I often like to lag screw, and of course where there's been significant bone loss or soft tissue injury, then we may use a plate and screws. And then when would I use an external fixator? When there's significant soft tissue injury, it's such that we cannot use a plate, and we need to restore the alignment and length of a bone, and at that point we would use an external fixator. We have some very expensive external fixators that are available to us, but actually sometimes I will use K-wires through syringes, and that also acts, a plastic syringe also acts as a really useful external fixator. So I'll go back to my principles to summarize. Actually, this is probably the most important slide for me. What are we trying to achieve? We were trying to restore hand function, not a nice X-ray. Please remember the soft tissues. We want to be able to reduce and hold so that we can rehabilitate very quickly, and we require a multidisciplinary approach. Okay, thank you.
Thank you, Zaf. Could I ask the audience, do please post your questions. I will ask them of each speaker. The next speaker is going to be Deb Stanton, and whilst Deb's loading her presentation, I've got a couple of questions. One was about, will there be a certificate of attendance? The answer to that is yes. They will be posted out electronically to all people that have logged in. And if we didn't make it clear at the beginning, I do want to make it clear now, we are recording the whole session, and that will be posted in an accessible part of the BSSH website. So it's a great pleasure to introduce Debs. I think Zaf's explained very well how UK hand surgeons treat their fractures. But equally important to the surgery to get a good outcome is the post-operative rehabilitation, and we are very dependent upon our hand therapists to help with that. So over to Debs.
Oh, hello. Did I disappear there for a moment? Hello?
Hi, Debs. We can't see your slide yet.
You can't see my slide yet. So I says I'm sharing. Can you see anything now? No, still not?
No, you're sharing, but you need to click on your presentation now, I think. There
yeah,
we go.
I have.
Yes,
Oh,
play that one now.
Ah,
there we go.
Okay. There we go. We're already there. Sorry about that, everybody. So I just want to introduce myself. My name is Deb Stanton, and I'm a hand therapist and have been working in hand therapy for quite a long time now, longer than I care to imagine. And what I'd like to do today is give you a brief overview of the principles of hand therapy and fracture management as we do them here in the UK. I'll talk a little bit about the team, which has been alluded to quite strongly already, and then go on to talk a bit about oedema management and pain control, mobilization and tendon gliding, the splinting, and just briefly touch on the importance of the patient-therapist relationship and information giving. So, okay, so what is the role of the hand therapist? Well, as you all know, the most common complication of hand fractures are not really the delayed union or the non-union or other fracture healing complications like infection, but rather the complication from reduced tendon gliding and tethering, which result in lag and loss of range of movement, stiffness and contracture, decreased muscle function. And these complications are more associated with surgical intervention and immobilization than when there hasn't been surgical intervention and immobilization. So final outcomes and return to function are dependent on not just all you lovely, excellent hand surgeons, but on the provision of timely hand therapy. Surgeons and hand therapists need to know each other, and they need to recognize the importance of working really closely together and communicating all the relevant information that we need in order to make decisions. So our aims are to prevent complications associated with edema and thus restore range of movement and restore function. And early motion is the cornerstone of therapeutic management because it's been shown to promote bone healing, soft tissue healing, decrease edema and therefore pain, and prevent stiffness and deformity, and thus promote functional use. However, without really good communication, instigation of early range of motion can be delayed and lead to poor outcome measures. And by good communication, what I really mean is communication between the surgeons and the hand therapists and the hand therapists and the patients. Everyone has to be on the same page about what needs to be done and when it needs to be done. Patients have often had a life-changing injury, and we're all experts, but they're not. And they find it really terrifying, and the more information they can get to encourage them to get moving in what sometimes seems like a very unseemly rush and very quick, better. So really, without knowing or your team and all their strengths and weaknesses, and also their level of expertise, then you lose the ability to discuss treatment options really thoroughly. And then you lose the ability to kind of optimize your outcome measures. So let's have a little talk about edema management. So it seems old-fashioned, but RICE is still the best sort of mnemonic. So rest, ice, compression, and elevation. And when we're talking about rest, we're talking about resting when you're not doing your exercises, rather than just resting. And when it's resting, the hand needs to be held in the optimum position. And we will talk about that in a bit more detail in a minute. But basically a position of safe immobilization, as we call it, a POSI position. So ice or cooling, just keeping the hand cooler. Obviously that kind of reduces the flow of all the exudate out into the tissues. And as we know, that exudate is full of horrible, nasty proteins that stick everything together, and we're trying to minimize that as quickly and as maximally as possible. The compression literally just reduces the space for the swelling to accumulate. And elevation, that's just using gravity. Gravity enhances our venous and lymphatic flow. And if our lymphatics aren't working and our lymphatic system isn't working, then we're not going to have much luck getting rid of all our nasty edema. So let's just move on a little bit to the splinting for edema. So as you all know, the edematous hand sits in the intrinsic minus position, if allowed, that is. And that position, as you all know, is to bring the MCPs into extension, the IPJs into flexion, and the thumb into adduction. And using a really good posi splint allows the hand to rest in the opposite, in the intrinsic plus position. Prevents shortening of the intrinsics, and reduces the amount of edema that can build up in sort of slack capsules that you would get at the back of the MCPs or on the palmar side of the IPJs. And this prevents stiffening of the ligaments in the shortened position. So I'm just going to show you now some lovely pictures from Donald Summit, who you all, I'm sure, know. And they're great pictures which really clearly demonstrate that if the MCPs are allowed to rest extended, then all these little collateral ligaments, etc., all around will shorten and tighten and get all scarred up with all those horrible proteins that are sitting in there, and hold the hand in the MCPs in extension. And if, however, the MCPs are flexed, then you can see those ligaments are on a little bit of tension, and so they're not going to shorten and tighten and reduce the range of motion. And on the other side, as you can see, the PIPJs, it's the opposite. So when the PIPJs are extended, then the collateral ligaments are nice and tight. And when the, sorry about that, don't know what's happened with the ligaments there. And when the IPJs are flexed, then you can see they're just in a much more slack position. So positioning of the joints in the hand is integral to edema management, but it isn't the only thing, as I've said. We also have, that's clever, I'm not sure how I managed that, but there we go. Just to not forget the other tenets, like the elevation. So elevation with the hand above the heart is the important thing, not below the heart. So just sitting in a sling with your hand around your waist isn't really ideal. So anytime above the heart is fine. The only precaution I'd put in that would be if you're anxious about your patient's arterial supply, then really, as a therapist, you'd need to talk seriously to the surgeon about whether it was appropriate to elevate the hand that high. If your patient can exercise with their hand in elevation, all the better. So then we've got gravity, we've got muscle pumps, we've got tendon gliding, we've got everything going on. And of course, compression around digits, compression around the whole hand, whether it's tubing grip, crepe bandage, fancy Coban, doesn't really matter. Any kind of compression is going to be really helpful, as long as it's not so much that you crush your lymphatics. So the next thing to talk about in terms of edema management and in terms of preventing contractures and optimizing outcomes for all of our patients and getting everything going is early active motion. So why? You might think, why put things under stress and strain? Why not just leave things for a little while to get heal a little bit more? Well, early active motion helps edema reabsorption. I mean, it's uncontestable. Facilitates fibrin and collagen alignment in your healing structures. Prevents the fibronectins and fibrin attachments to adjacent soft tissue, so stops your tendons getting stuck to your capsules and your capsules getting stuck to your tendons, and everything getting stuck to the bone and the skin getting stuck to the scar tissue. And promotes collagen elasticity. So as it moves and the new collagen is laid down, the collagen fibers are laid down in a more striated, less disorganized pattern, and that helps give you scarring, which has got more tensile strength, more elasticity. But we need to protect. So we need to know what is stable, and this is where you as hand surgeons are really important, because we need to know what we can move without putting whatever you've done at risk if you've done something. So in this first picture on the left-hand side, in this picture, obviously the wrist has been immobilized, the MCPs have been immobilized, but in flexion. But with this plaster of Paris cast, you can still get really good IPJ flexion. You can get individual FTP flexion just by flexing the DIPs, and you can get combined FDB, FDS flexion by doing composite finger flexion. You can see there's a buddy strap sitting in here, and that's just to, as you all know, to help with any type of rotational deformity, stops an unfortunate lateral pressure which you might get if that wasn't there to protect the fracture, the metacarpal fracture. In the middle one, we use this fancy stuff now. It's called All-Fit, just because it's very light and very easy to use, but it's just as possible to make this type of splint out of POP. And this one, where you're still wanting the MCPs to be held in flexion to perhaps stabilize a metacarpal neck fracture, or even a proximal phalanx, very, very proximal articular phalanx fracture, but allow the wrist to get going and the wrist to get movement, and then you could do some nice tenodesis work at that wrist to make sure those tendons are gliding. But once again here, we've got the IPJs nice and free so that we can get them moving really early. And sometimes we use plaster of Paris and just make bits and pieces and slabs that you can take on and off to do all sorts of different exercise. So with something like this picture on the right, when you take off the straps, you could either take off the strap and maintain a flexion block to prevent too much flexion, but do extension work, or alternatively, you could take off the palmar block, keep on the extension so that you're not overextending if that's not supposedly stable, or if that's not ideal in terms of the fracture, but allow good flexion at all the joints. So lots of different options, and it really is all about protecting. It's about knowing what's stable and therefore what you can move. So there's lots of different parameters in early active motion, and I'm not going to go through the whole slide because it's very busy, but I think really what I'm trying to get across here is that early active motion isn't an all or nothing thing, and it could be something as simple as just initially doing isolated FDP work to get an FDP to be sliding down past the IPJs to stop that tethering, literally just the DIPs moving at the beginning, if that was all that was allowed, to full composite movement. And it can be assisted active motion, and it could be in one direction and not another direction. It could be two joints, it could be the whole hand. So there are a lot of different parameters to consider, and there is not really ever a point or a stage where nothing can be moved. So no hand should be left not moving, I suppose is what I'm trying to say. Anywhere, there's always got to be something that can be moving to try and stop those adhesions and prevention of long-term deformity. So active exercises could include anything from these top two pictures here with the blue and the pink splint. We do make these out of plaster as well. So this will prevent full extension at the PIPJ if you had a fracture dislocation, but you can undo the straps one at a time and do some isolated FDP and then do some FDS and FDP to get those tendons gliding really nicely past each other. But the splint at the back blocking that extension and preventing damage or undoing the good that's been done in any surgery. It could be something as simple as using the body straps to promote movement and protect. And we always show patients really carefully how to do their individual FDP and FDS glides and give them nice little handouts with pictures on so they can see really clearly how they can do it supported. Same picture again there, but just showing that active exercises can be done in all sorts of different situations. So tendon gliding. Why do we tendon glide? Well, tendon gliding obviously gets the tendons gliding past the structures that we want them not to get stuck to, but also tendon gliding reduces edema. But what you want to do is get as much differential glide. So not just gliding the tendons over the bones, but gliding the tendons past each other. And the tendons that are done the most badly, if that's correct English, are the tendons of the EDC. Most tendon gliding regimes involve as much of a straight hand or a straight finger, and then various amounts of bending at the end or bending a hook and doing lumbricals. But very rarely do they take the patient from a fist to a hook position. And so that's this bottom one, and that's the one that makes the EDC glide the most. So when we're getting to later stages in rehab, tendon gliding sequences are very helpful. So the straight hand, obviously, not much gliding going on there, but when you perform a hook movement, that's when there's the most differential glide between the FDS and FDP. So they're sliding past each other the most. When you then go into a partial fist here, that's when there's the most excursion of the FDS through the wrist and hand. And then obviously when you come into a full fist, that's when there's the most excursion of your FDP. So regimes like that are common, and they're on lots of handouts and sheets that are given to patients, but that doesn't mean that they're not really useful and really purposeful. Sorry, I'm just slightly struggling to get to my next slide. So passive range, when can we start it? We can start it at 4 to 6 weeks. You can do isolated and then composite range. Passive range might need to be helped along with splinting if things have got a bit stuck. And using heat to aid passive range is very easy to do, and it gives you just a little bit more extensibility, and the collagen likes it. So heat before passive stretches is always a good option. And then moving on to more functional exercises, there's all sorts of things you can do. There's scooping up rice, beans, lentils, lovely for desensitizing sore hands. Using pegs to stick sticks into foam. Giving out handouts with pictures of all the different grips is always helpful, so patients know the sorts of things they should practice. And obviously the good old ball, but it could be a squash ball, it could be a lump of dough, it could be some salt dough, it doesn't really matter, but functional exercises, starting to get some resisted movement as soon as you're allowed. There will always be complications, no matter how hard you try, and no matter how much early active movement you do. And these are just some little ideas of relevant of splints that can be used to help with complications. So in the first one, the relative motion flexion splint here. So the patient is struggling with PIPJ flexion. You can block the flexion. And then when you make a fist, you can see it just encourages that finger to hook well over that PIPJ. And you can do it the opposite if you've got an extensor lag. You can block the extension there. And serial splinting for PIPJs that have become developed fixed flexion deformities. Really successful, bit time consuming. Patient needs to come back relatively frequently, but very positive results from POP serial splinting. I have got a couple of little videos to share, but I'm not quite sure how to do that. So we'll just have a little look at this one last slide, which I'm sorry hasn't got the BSSH logo on it, but I couldn't quite manage to insert it. I think there's one thing to remember, which is oft forgotten, is that the intrinsics of the hand contribute to 48% of the grip strength. And we're very good at getting people to do
we seem to have lost Debs at the moment. It's been an extremely comprehensive talk, and many of you will probably want to watch it again. There will be links posted both on the when you get your certificates of attendance. So there was just one question around Zaf's talk from Mohammed Ahmed about Zaf. Are you hearing? About when you're doing your close reduction of fractures with a clamp, how do you avoid the neurovascular structures?
It's a good question. So strictly speaking, what you should do really is dissect down onto the bone and take care to, like a mini incision. I think as you become more proficient, then you will have some understanding of where your neurovascular bundle will be, which is slightly more volar, and then you should be safe going directly onto bone, particularly if at the PIPJ, for example, you're close to the condyles, you're going to avoid the neurovascular bundle. If you're holding the condyles, say it's a distal shaft fracture or a condylar fracture in this situation, then you should be safe because you'll be where the collateral ligaments are and be able to hold the bone with your clamps that way. Similarly, when you're inserting K-wires or actually putting a screw in, you can make a little mini incision and then blunt dissect down onto bone should you wish to.
Okay, so we seem to have lost Deb, but we have got Kemi very visible, so I think we should move on to the next talk.
Thanks, Stephen. Can you see my slides?
Yes, very clear.
Okay. So good evening to colleagues from all around the world. It's my pleasure today to share with you the West African perspectives to the management of hand fractures. And having listened to Zaf's presentation and then listening to mine, you would agree that there's a huge difference in resources available to both of us to manage the same pattern of fractures. But where we differ on the amount of resources, I'm happy to tell you, Zaf, that you have similar Premiership club with my son, and he just told me right now to ask if he will be watching the match later on today. Yeah. Okay, so I will just be giving us what we do, how we do it in West Africa. And next to the brain, I think the hand is the most fascinating and complex organ in the human body. It has an intricate design, numerous potential spaces, different tunnels and arches, gliding tendons. All of these are difficult to replicate when damaged. And our nightmare as plastic surgeons is, after having done a beautiful surgery, you end up with a very stiff hand. So we take hand therapy very seriously. We have a lot of presentation of hand fractures in our emergency room, and our prompt evaluation at the first contact with the patient and subsequently during their treatment would prevent significant morbidity and mortality and disability to the patient. And our goal is rapid and full function of the hand, because after having restored the function, we are actually preserving the livelihood of most of our patients. As has been said earlier, you would agree that a fracture is best described as a soft tissue injury with a bony component rather than the other way around, because even the most trivial of fractures has some degree of soft tissue affectation. And there is no way you can describe management of hand fractures without addressing the soft tissue. However, the way this seminar is designed, I think we're just focusing mainly on the bony aspect, and the later session will address the soft tissue aspect. In Africa, and I think it's similar to what obtains in the UK, plastic surgeons mainly handle hand fractures distal to the carpal bones. The orthopedic surgeons handle the wrist fractures. And in describing our fractures, we usually use the names of the digits as displayed above rather than using ambiguous terminologies like D1 through to D5. There are many causes in our environment which is similar to what obtains in the UK, but commonly here we have a lot of factories, especially in our cosmopolitan area in Lagos. We have a lot of small factories with poor safety protocols, so we have a lot of crush injuries from machinery and from, of course, fights, as you can see displayed above. And these are some of the scenes that we see frequently in our emergency room. And the other aspect of this is that most times patients don't want to have their hands amputated because we don't have good enough prosthesis. So if they don't have enough prosthesis, they will rather preserve what function they can retain of the hand. Sometimes they present with closed injury, where the only link or the only inkling to a fracture will be a persistent swelling and point tenderness on palpation. And sometimes they present with obvious deformity, amputations, and significant soft tissue loss. X-rays are our mainstay of confirming our diagnosis. Rarely do we need to do MRIs to confirm our diagnosis. And as at the time we are evaluating the patient with fracture, we usually assess the potential to healing of such fractures by assessing the adequacy of blood supply, availability of periosteal covering to the fractured ends. We usually aim to achieve direct healing, but because we can't achieve stable fracture stabilization, usually what we have is healing with secondary intention with some callus formation. We still all the same principles as Zaf has said by reducing the fracture. Usually we would reduce dislocations and most fractures in the emergency room under light sedation, because getting to the theater quickly may be a problem in our setting. And if the injuries are close, we'll put in a cast. But if there is swelling, we usually make do with usually a volar slab till and then elevate till the swelling subsides before we usually use a cast or splint. When we have patients with metacarpal fractures, usually our line of management is dependent on what we find on clinical examination and the radiological features. And especially when we have fractures of the neck and the shaft of the metacarpal, we would assess for rotational deformities by asking the patient to make a fist and seeing the alignment of the fingers. In cases where they are not able to make a fist, we will try to achieve the tenodesis effect by gently flexing and extending the wrist joints to see this. And we should be aware that rotational deformities most times are not captured on the radiographs. The commonest metacarpal fractures we see are those of the neck, followed by the shaft fractures. And when the metacarpal head fractures are rare, and when they do occur, actually difficult to treat. When we have a metacarpal fracture which is closed and the x-ray, the fracture appears stable, we would usually do conservative management. And when there's significant or some angulation, we use this maneuver to try to reduce the fractured end by flexing the metacarpophalangeal and proximal interphalangeal joint and applying pressure to the dorsum of the metacarpal as shown in this maneuver. Thereafter, we put them in a splint in position of safety, just as Deb has told us the reason why. Sometimes, after doing a check x-ray, we'll find that the reduction is not acceptable as seen in this check x-ray, and in such instances, we may offer operative reduction. Other instances where we ask for operative reduction or operative management of metacarpal fractures are when we have significant rotation or angulation, intra-articular fractures, or fractures with significant soft tissue injuries and multiple fractures. The choice of what we do operatively depends on what we have available, the resources. As Dr. Abikoye has rightly elucidated, we are a low resource setting, so we don't have access to most of these exotic things that Zaf has said. What we usually do is our K-wires. Another limiting factor is that most times we don't have intra-op imaging for management of these fractures. I have put this slide up because sometimes when I fantasize about what I would like as my ideal hand surgery practice, the top row are things that are on my wish list. However, sadly, in our environment, what we have to make do are things on the bottom list. Most of our fractures are fixed without intra-op imaging. Usually we would fix a fracture and then patient gets out of theater and goes to have a check x-ray. Our hearts are in our mouths as the fracture, the check x-ray comes back usually the next day or same day, and then we pray that the fracture reduction is satisfactory, because most times we don't get a second chance to go to theater to have a redo. For fracture of the shaft and neck, usually we do a single K-wire or crossed K-wire for more stability. We usually don't do IM nailing or screws. When we have open or compound fractures, we take them to theater for a debridement and thorough irrigation. We try as much as possible to put in the K-wires at that same sitting if the wound is not grossly contaminated or infected, because as I said, patient may not be able to afford to go back to theater, and we cover with antibiotics. As you can see from this x-ray displayed above, we did this without intra-op imaging. Usually we try to gauge our reduction by palpation to see if it's adequately reduced, and we try to gauge the depth of the K-wires going in by guesswork. Actually, as you can see here, we went too deep into the carpal bones, and when we see this usually on the ward round the following day, we will try to gently retract the wires by the bedside, of course trying to avoid accidentally pulling out the whole K wire. For injuries of the thumb, like the Bennett fracture, where there is some dislocation or displacement of the fracture segment, we would go in, open and put in a K wire. But if it's a Rolando that appears stable on X-ray, we would manage conservatively with a cast. Thumb metacarpal phalangeal dislocations are quite common, and usually when they present on time, we will try to reduce the dislocations closed and apply a cast. But most instances, the most common scenario is that they would present with you weeks later with a painful bulge in the palm and difficulty in flexing the thumb. And in those cases, a closed reduction may not be possible. So we would need to go in and try to reduce it, open, and then use of K wires will depend on if the reduction is stable or if it keeps dislocating, we might need to fix with a K wire. For fractures of the fifth metacarpal head, we will reduce, as I showed in the previous maneuver, the jazz maneuver, and manage conservatively if the reduction is acceptable. Otherwise, we may need to put in K wire. Our splints, usually we use POP, which is cheap and readily available, and as I said, we put them in position of safety, and we usually put in the cast for minimum of at least 3 weeks before we remove and start mobilization. For distal phalangeal fractures, usually they are open and the ends have tiny fragments. So most times we try to strive to get closed conservative management. When we have nail bed injury, associated nail bed injury, we would go in and remove the nail, try to repair the nail bed, and then use the nail as a sort of splint for the fracture. When we have subungual hematoma, we use the maneuver of a paper clip to decompress and then put in a splint. Mallet fractures are also common. Usually they present late because most times it's a trivial injury and the patient does not really consider it a problem until a few weeks later when he sees that there's persistence of the deformity. And when they present early, we put them in a mallet splint for 6 to 8 weeks. Even sometimes when they present about 4 weeks later, we would still put in a mallet splint for about 6 to 8 weeks. For phalangeal fractures which are undisplaced and closed, we would usually body strap the digits to the adjacent unaffected digits for a period of 3 weeks. When we have open fractures of the phalanges as seen above, we would use external fixators when we get them to use. And as you can see from the picture here for the x-ray, the fracture is not well reduced because of course we did it without imaging, and the pins are advanced too far into the joints. Sometimes we just put a K wire, and when we have a comminuted fracture of the phalanx just as this, we try to avoid putting in a K wire for fear of further distracting these fracture segments. So usually we'll put in a back slab and manage the wounds conservatively. For all intra-articular fractures, as a rule, we warn the patients that they are going to have some stiffness of the joint and inability to move the joint prior to treatment. And usually, as I said, prosthesis is not too good in this environment. So when we see crushed or mangled injury, we try to preserve as much of the digits as we can. In this instance, there was significant loss of the proximal and part of the middle phalanx, but the tip and the distal phalanx was viable. So what we did was to put in a K wire to join the remaining part of the middle phalanx to the metacarpal, and it ended up with a shorter finger, but it was still there as in a supportive role. Also, we have scenes like this where there is significant soft bony loss. However, on examining, the tip of the thumb and the ring finger still appeared viable. So we didn't want to amputate the digits despite the loss. So we filleted the middle and index finger and took some parts of the bone and used it as a strut to the thumb and the ring finger. So we're able to achieve this, looking ugly, but the patient was still able to use it in a supportive role. So hand therapy is key, whether the fracture is treated conservatively or operatively. As a protocol in our centers, usually a patient we admit either for surgery or for other care is pre-billed for physiotherapy. We don't have hand therapists per se. So usually we'll explain to the physiotherapist what we want done, and usually the sessions take place about 2 to 3 times a week on the wards. And on discharge, we also send them to the occupational therapist to optimize their hand function. Thank you very much. You are muted, Stephen.
Thank you, Kemi. That was really good, and makes us, all the UK audience, really appreciate how fortunate we are. Some fascinating cases. Some of those cases fit in well with our next webinar on October 10th, which is about soft tissue cover, where the actual fracture is probably a small part of the injury, isn't it? And I think the case discussions will lead us into that territory as well, really. I just want to read out one question that was directed at Debs from Adnan Al-Mufli. When use ice and when use warm in treating edema?
Oh, hi, Steve. Thanks very much for the question. The more acute, and basically the hotter the hand is, the more acute, and particularly in the very, very early stages of inflammation, you want to use ice and cold. You don't want to heat up something that's already massively vasodilated and exuding lots of horrible stuff into the interstitial space. So you want to use the cold to dampen that down, to reduce the vasodilation, to stop the capillaries opening up and sending all those horrible proteins in that are going to stick everything together. As the edema moves through the stages, from the acute stage up to kind of day 7-ish and then into the sort of subacute stage, you would still use cooler in that period. But as the edema starts to pit and becomes a bit more inured into the tissue, then I would probably trial warmth at that point, because you want to soften up the tissue and just see if you can get everything moving a bit more. So you're not using the warmth for the same reason that you're using the cold, is probably the short answer. So the cold is to reduce the acute inflammation and edema, and the warmth is to soften everything up so you can get it going. I hope that answers your question.
Thank you. So we'll now move on to the case discussions, which are going to be presented by Phalake. That really will give us a good opportunity, I think, to reinforce many of the principles that have been outlined in the earlier presentations. So over to you, Phalake.
Thank you, Steve. Thank you for the presentation. I just would flip through some cases, and the panelists will be able to discuss this. I have this picture of a patient, a 43-year-old man who had a 2 days history of open injury to his right hand, to his left hand, to the left hand. And if you look at on the right side, this is the X-ray. So this is open for discussion, please. Kemi, your comments, please.
Yes, thank you, Phalake, for this. This patient presenting with significant degree of soft tissue injury, and it looks to be some form of crush. In my center, this qualifies for an open reduction, and trying to, for this one, that's the middle phalanx, the proximal phalanx is dislocated, we'll try to reduce that and try to put in a K-wire. Here we would, the joint, the middle interphalangeal joint seems to be lost, so we might have to warn the patient that they may have some degree of stiffness and inability to move the joint if this heals as a whole. And I will be very wary of trying to put in a K-wire into this to try to avoid distraction. Of course, if I have access to external fixator, this will be a good time to use that to try to just manage the fractures as it is. Thank you.
From DAF.
Thank you, Falaki. Falaki, are you able to play the, we were just getting some comments. Are you able to go into slide presentation view so that people can see the full picture? Fantastic, thank you. So obviously I'd agree with everything that Kemi has said, and I'm absolutely sure that the surgeons in West Africa and other parts of the world have far more experience in multiply injured, severely injured hands than the surgeons in the UK, largely down to our better laws now in terms of industry and road traffic laws. So our exposure to these injuries has reduced over the years. Having said that, the principles remain the same. Obviously, as mentioned by Kemi in her lecture, that we need to think about the patient in total first. So we would do that. There may be other more pressing injuries, and focusing on the hand. Debridement is really important. This is 2 days old now, and we need to remove any dead tissue. So that's the first thing. Copious irrigation, and then to really assess what is viable and what is not. Kemi has already pointed out that the MCPJ of the index finger and the PIPJ of the index finger and the middle finger, both of them look highly unstable, and so there is going to be a problem here in terms of having any joint movement there, because I think, even with the use of a dynamic external fixator, the ability of those joints to function as joints is going to be compromised, and we may end up having to fuse that. The other thing is, once we've done a full debridement, we would then be able to understand what soft tissue is remaining. So we've got to think about our nerves. Is the finger going to be sensate, the index finger? Looking at the picture itself, there is potential promise that maybe that on the ulnar side of the index finger there is a viable nerve, but I don't know about the radial side, and this has an impact as well, because if we have a functionless digit which is insensate, then although initially we will try and preserve, ultimately it may be not of any use, and it may be quicker for the patient to be rehabilitated without that digit, or with that digit trimmed back, and then the thumb can then oppose the middle finger if the middle finger is a bit more stable. And then in terms of the bones, as Kemi has mentioned, we would try and fix what we can, although I do worry about the proximal phalanx of the index finger in terms of what is salvageable there. I'm not sure that there is, I think there's difficulty there in terms of what we can fix. But on the other view, you can see that there are at least two decent pieces that we could try and fix by K-wires.
Thank you. Debs, any contribution as per hand therapy for this patient?
Well, I think probably just in terms of importance, when the patients had whatever surgical intervention they're going to have, and even between, if they're going to have more than one, really essential that this patient maintains their wrist range of movement, if that's going to be possible. So whatever's put on, afterwards if it can be either removed to allow wrist range of movement or not include the wrist. That would be very important. I think showing the patient how to maintain gliding of their FPL on that thumb and to make sure that they don't lose any thumb function, because this hand isn't going to be a brilliantly functioning hand. So we want to make sure that that thumb is as good as possible. So get the thumb and the little finger opposing really early so you don't lose that transverse arch and you get really good gliding of the tendon and use of the muscles of the thenar eminence there. And then I would also advocate early tendon gliding in the ring finger and the little finger, looking particularly at really stabilizing those two fingers and getting DIPJ flexion and isolated PIPJ flexion in those two as well. So although the other two fingers are obviously going to require lots of therapy in the future, we just have to keep whatever else is in the hand as good as it can possibly be, so that the rest of the hand doesn't stiffen up and they don't lose their whole hand function.
Thank you, Debs. Well, this is another patient, a 33-year-old right-handed man who had his little hand caught in the front belt of the machine in the factory and presented 3 hours post-injury. He had good capillary refill to all the digits. As you can see, he has a ring in place, and this is the X-ray picture of the hand and the X-ray. Zaf, please could you go ahead?
Yeah, so yeah, ring avulsion injury. The good, as you said, you've got a good capillary refill, but we would have to really explore the neurovascular bundles on both sides to assess the viability of the digit, but that is promising. We need to remove the ring, obviously. We would do all the precautionary measures we've previously discussed in the last case in terms of debridement, washing, antibiotics are all really important things not to forget. When it comes to the proximal phalanx, it's difficult to see. I can't clearly see the middle phalanx. I think the middle phalanx is also fractured as well, and therefore I imagine the PIPJ is also potentially injured. I don't know what that joint is like, because that would be important, but we want to get down, we want to fix the bone. Potentially there's some good soft tissue there, so with a metal plate, a mini plate, and repair our neurovascular bundles on either side, and then deal with the soft tissues in terms of allowing healing of the soft tissues. With respect to the PIPJ, I can't clearly tell. Obviously, if we have an intact PIPJ, then that's great news. Otherwise, that will also need to be addressed by stabilizing wires in the first instance.
I think the ring still being in situ actually obstructs the picture, the image of the PIP joint of the ring finger here.
Yeah.
Can you give your comments, please? Can you discuss this? Kemi? Kemi? Hello, Kemi? Kemi? Okay, I think she's...
Kemi is back.
Yes, I'm sorry, I had some internet connection loss there.
Okay, then.
So for this particular digit, I would be wary, because removing rings is actually a tedious process, because in trying to remove the ring, you may actually now devascularize the digit further, and we can't leave the ring in place. So I agree that the first thing is to try to remove the ring and try to see what is left if the digit is still viable. I'm not sure, because there's a some bone loss here. I'm not sure what we can achieve with trying to fix this with a K-wire. I'm not sure what we would, but what I will do will just try to put the hand in an anatomical position and try to put on a back slab and just wait and see, really. So if after removal of the digits, a week down the line, the hand appears viable and some of the injuries are getting healed, we may now go in and try to dock, as we did in the last case I presented, try to put a K-wire to dock the ends of the fracture together. But it really is actually a difficult case to manage.
Okay, I'll move to the next slide. Well, this is not a fracture per se, but this is some bone loss. And this is the clinical picture of the hand, and the X-ray shows some bone loss, and he desires improvement of the hand. Who will start first? Zaf?
Thank you, Falaki. Yeah, so tricky because it appears he's got a viable finger from the photograph on the left, but we have this gap. So the choice is really to whether we can actually put something in place here, some strut or bone tissue, and maybe stabilize the proximal phalanx on that strut. So fuse it there potentially. Versus doing a shortening, bringing things down, and then having the finger shortened. But in that situation, then the thumb will bypass the index and go to the middle. But you may have, and it would be difficult when making a fist, etc. That you'd have essentially like a shortened index finger, which would perhaps still have some use in terms of making a grip. Those are our options, really. So I think that we could place a piece of a strut graph there, and then strut from the base of the metacarpal onto the proximal phalanx probably would be my preferred approach.
Kemi,
Yeah, I agree with Zaf, but I think I have an idea of what was done to this patient, and what was done was to put a strut, but where they got the strut was from the fibula and acted as a strut. But of course, we would know that the functionality of the metacarpal phalangeal joint would be very technical. But I think that was what they eventually did. If Falake has post-op X-rays.
No, I don't have a post-op X-rays. I just put a slide per case. Thank you. Okay. This is another case, a 19-year-old right-handed man who presented 2 days post-injury. The wounds had already been sutured by the person who resuscitated in another center and was referred to a tertiary center for management post an industrial accident. The X-rays are shown beside the picture. How would you like to manage this, Kemi?
Oh, well, these are quite common scenes that we see on a regular basis, and usually they've been to another hospital where some mass closure has been done, and we can see rotational deformities. And this is clearly an indication for open or surgical management. And what I will do will be to put in K-wires, and ideally I want to put one into the thumb and another one into the index and the ring finger. After fixing that, if it reduces, because in some instances it reduces this fracture, so we may do without. But if this is still displaced, we will need to put another K wire into this. And of course, putting the K wires would try to have preserve as many joints as possible. So we'll probably go in through the base of the proximal phalanx and then try to gauge blindly, because we don't have intra-op imaging, try to gauge the reduction and the depth with which we put in our K wires to avoid going too deep into the carpal bones. And basically, I think that's what we will do.
Yeah.
Thank you, Falaki. So I would agree with everything Kemi has said. I think it's remarkable that you have to try and manage these cases without intraoperative X-ray, Kemi. I think I would definitely struggle trying to do these operations without X-ray. But yes, essentially K-wires, although we are not going to get the stability we really want that we would get from a metal plate, but we've got to consider the soft tissues and the overall load of metalwork. And so often with these kind of injuries, we will use multiple K-wires and try and get a solid base for these fingers by having a solid platform of well reduced, well aligned, and hopefully healing metacarpal fractures. But that would be the way forward. I don't know what, I mean, it's difficult to see from the picture, but I imagine there may also be some, I don't know what the tendons are like as well. They may need addressing.
Yeah, I think this patient had extensor tendon injuries.
Yeah, so they would have, yeah, so you'd imagine they've got extensor tendons which will need addressing, and then the problem will arise in terms of extensor tendon adhesions and trying to mobilize those extensor tendons whilst immobilizing and the bone, trying to immobilize the bone. And that's probably another reason why we would tend towards K-wires, multiple K-wires than plates. But you know, we possibly, where possible, I would maybe the thumb, for example, use a plate there if there is no other soft tissue injury there, to get some early stability somewhere.
Thank you, Zaf.
We've got a couple of questions about that case, which is a fascinating case, because I don't like plating metacarpals, but that's perhaps one case where I would, as Zaf says, plate them so we can get them rigidly fixed and mobilizing. But I just want to ask Kemi, really, tips as to how to get those K-wires as optimally placed as possible without an image intensifier.
That is a tough question, because what we usually do is palpate, fix, and as a consequence of not having imaging, we keep going in, remove, we're not happy, so we keep damaging the articular head, because we have to try multiple times to get it as perfect as we can. So it's really a tough job to try to get them well aligned using palpation.
Do you use the retrograde technique for inserting the, because the fractures are exposed, I think, there, aren't they?
Yes, we do. We do the retrograde mechanism, going through the fracture segment because it's open, go out through the proximal phalanx, and then drive the K wires in. And of course, we can visualize the reduction. If it's an open, we can visualize the reduction.
Yeah.
I think more of where we don't have the mini CM for image intensifier for visualization intraoperatively, the retrograde technique is commonly being used for management of those fractures.
Yeah, and I think we'd be happy to take it out through the metacarpal head with the MCP joint flexed, and then drive it back in.
Yeah. This is another case, a 30-year-old right-handed teacher who presented with a 2 weeks history of trauma to the hand.
Sorry, just another question about that case. Sorry for lack of. about addressing the fracture stabilization and extensor tendon repair at the same time. I think that might be a question as much for rehab as surgical technique.
Hi, Steve. Is that directed at me then?
Yes,
Yeah,
please.
I think so, because I think as surgeons we would want to address both at once, but rehab of a fracture that's maybe not as rigidly stabilized as with a plate. You'd be still wanted to get some movement there, wouldn't you?
Yeah, really complex, because obviously with all those metacarpal fractures, even if we were to try and get some tissue mobilizing through the wrist, you're at risk of kind of destabilizing things there. So it would be really complex. I think possibly if post-surgically the wrist is placed in a decent amount of extension in 40 degrees, if that was possible, if that wasn't going to upset the balance of what had been done with the K-wires, then you could safely then do some stabilized individual IPJ work, really gentle, maybe active assisted, just to start getting a little bit of mobilization. But that would have to be something that you'd have to have a lot of discussion with the surgeons about what had happened and how stable they thought it was. But I think the position that this is splintered in is going to be key, isn't it, afterwards, in terms of what kind of function they're going to get in this hand. But yes, if the wrist is extended a bit so the extensors aren't on too much of a stretch and the MCPs are as flexed as they can be with the K-wires, then you could start some gentle active flexion extension at the IPJs.
Thank you, Debs.
With their arm up high in the air.
Thank you. We'll take this case, the 30-year-old right-handed teacher. X-ray is as shown. Zaf, your comments, please.
So we have fractures which are very close to the joint. The fifth metacarpal head seems completely off. It is off at the neck there. This needs to be restored back in position. It's 2 weeks old, which isn't great. It's not going to help. The question is how to hold the head of the fifth metacarpal back. That is the question. There are metal plates which are T-plates with locking screws that we have, which we can place on the dorsal aspect. The problem there, as I've mentioned in my talk, and I repeat, is that it will invariably cause problems in terms of the joint capsule and the extensor tendons, particularly the joint capsule. And so whilst we could restore the head back, there may be quite a bit of stiffness at this knuckle, and we all know that if you cannot flex and make a full fist with your little finger, you lose quite a bit of your grip strength, a substantial part of your grip strength. An alternative could be to use K-wires. It's technically challenging, and again, you're going through the capsule and you're very close to the joint, but that will be an alternative. But I think something will have to be done. We can't manage this. I think it's very difficult to manage this non-operatively. There is also a fracture of the fourth, but I think it's relatively reduced in comparison, and so I'd probably leave that alone unless there was other images which showed me otherwise. But this does need addressing, and it's either an ORIF for me or K-wires, but it's not ideal, the position of the fracture, and I will be warning the patient that I'm concerned that they may end up with some stiffness at this knuckle.
Okay. Kemi, how do you want to manage this?
Well, K-wires it will be for me as well. if there was intra-op imaging, I would have tried to do it closed, try to reduce and manipulate. But in the absence of that, it will have to be open and then try to reduce manually and then put in a K wire. That's what I will do.
Well, I think it many a times the boxes fracture, if it wasn't displaced, could be managed conservatively, but because there is a significant displacement, I think that's a great problem here. And the availability of the mini implants to use may be an issue in West Africa, but I'm sure if that was available, that would have been a benefit. Yes, what would be your inputs to managing this patient as a hand therapist?
Well, I would hope that after their surgery, the patient will present to me either in a plaster which has the MCPJ flex to sort of 50, 60 degrees if possible. If they come with all their bulky dressing and we've been asked to make a splint or a plaster, then and that's stable, and we've had lots of excellent information from our hand surgeons with reams of operation notes telling us exactly what's going on. Then with the MCP held in that position, then we can start active supported IPJ flexion extension straight away. And because this is a very distal fracture, we can actually start wrist flexion extension straight away. Have to be super careful to make sure the other fingers, particularly the middle and the ring fingers, don't get stiff, particularly that ring finger because of that fracture there. So it'd be the same thing. I'd try and get away with an ulnar-based splint or orthosis so that the rest of the hand can get on and can get moving. But yes, MCP still and steady for the first couple of weeks. Get lots of IPJ flexion. Get the wrist going, and then at about 3 weeks, it would depend on the state of the person, you know, diabetic, smoker, etc., 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 and how the fracture healing is going, when I would actually start getting some MCPJ movement. But maybe 3 weeks, maybe 5 weeks, just depending on how stable it is. But definitely getting those tendon gliding really early and making sure that that MCPJ is not fixed in extension whilst we're waiting for it to heal. That's the key thing there. Otherwise, it's going to be stuck straight and they'll never get it going.
Thank you, Debs. I just want to ask you, Debs, if you'll still be willing to show the video. So probably after the last case I'll project, then you would share your
Okay, I hope they don't disappoint. They're not the most exciting videos in the world.
Okay, so I'll just show a last case and probably you prepare for to show.
Yeah, I've got another question, and it's from a UK surgeon. I think all the UK surgeons are reflecting on the challenges of K-wiring displaced fractures without image intensifier. But it's from Barbara Jemek, who's asked a question to Kemi, really. Do you ever open fractures that aren't originally open fractures just to ensure you get an anatomical reduction before inserting the K-wire? I guess it's the balance of risk of introducing the infection versus getting a good fracture reduction.
Yes, definitely. We try as much as possible to avoid open. So we'll usually do a closed reduction and try and see. But then you are in theater, you can't afford to come back if you don't get it the first time right. So usually we would opt to actually open so that we can visualize that it's as perfect as we can make it. But I agree with her that making small stab incisions rather than making a really open injury to assess the fracture site may be a good idea and something I'm willing to consider in future.
Thank you.
Thank you. So I think this is the last case that I'll be showing. 60-year-old right-handed school principal who had a fall, fell on the right hand and sustained this injury. How would you like to manage this patient, Kemi?
Yeah, for this, if it's a closed injury, I would manage conservatively, put in a splint, and hope that the fracture does not displace and heals as it is. That's what I would do.
So with these injuries, they can be relatively undisplaced clinically, and obviously what we need to do is assess where the fingers are in terms of their rotation. I don't think the shortening is too much of an issue. I think the issue is the rotation, and so we would assess the patient in clinic to attempt to make a fist if it's not too painful. And that would help guide whether we need to intervene. If there's significant malrotation of the fingers, I would probably intervene. If the patient cannot make a fist due to pain, then we will look at the nails on the end on, as I'm doing right now in my screen, and to see which way the nails are tilted and compare that with the other hand. That will also give me some indication of how much malrotation there is. If there's not much malrotation, then I would agree with Kemi that we could buddy strap the fingers to try and maintain some good alignment and get them moving early. And because we have this box concept that the index finger metacarpal and the little finger metacarpal on either side of the fractures or the fractured bones are acting as struts for us. And then we've got the transverse metacarpal ligaments at the head, and then we've got the CMCJs at the base. All of that gives us a box around which these fractures are already splinted in a way. So therefore, that all leans to conservative management. If there's significant malrotation, then my preference would be to distract the fracture, i.e. reduce the fracture, and I would then use a metal plate on the dorsal aspect of both bones. But again, you know, if we're going to do that, we need to be committed. In fact, actually, probably looking at it now, I would probably, rather than use a metal plate, I'd probably do lag screws. If I can, if I need to, then I could supplement a metal plate, a plate on top. Lag screws preferably, because then we avoid a big plate under the extensor tendon. We can get a good hold. If a plate is required, then add that on, and maybe on the radial side there's a possibility. I think so on the radial, on the ring finger metacarpal, there's a possibility of needing a plate there proximally, and then. But we have to be absolutely sure that we're going to get a good reduction and a good hold, so we can start mobilizing early, because that's the point of doing this.
Thank you very much, Steph.
Okay.
I think Debs, I don't know if you have any comments on the rehabilitation and then your videos, please.
Hi. I think I just really reflect what Zaf has said, and you know, the idea is, you know, get these moving really nice and quickly. I mean, obviously you have to be very careful, as I said before, that you protect and you don't create any rotational deformity, shortening, anything like that, if it's just going to be managed conservatively. I think probably myself in clinic, I might be a bit inclined to stabilize the wrist quite a lot when they're not doing their exercises, but they could do an early active motion regime really probably from day 3 without any problems at all. But these get horribly swollen, don't they? And then the extensor tendons and the EDC tend to get horribly stuck down on these. So really trying to get the EDC working as quickly as possible and as well as possible, and get as much gliding going, the better, and lots and lots and lots of edema management. You know, get that hand up in the air, cool it down, get them in a really good position, and start moving really safely, really early. Oh, I'll try and, do you want me to try and share those videos now?
Yes, please.
Okay. So, as I say, I hope they're not really disappointing. if I can do it. Oh, no, that's you. Okay. It doesn't.
I think, Dr. Apikoye, you need to unshare your screen first. So that you can...
What I'm trying to do, I want to unshare, though it's not responding. So I'm just giving it a little tweak. I'm sorry. I think the system is not responding.
No.
Okay. It's still not responding. It's playing up. I'm sorry.
Can anybody see that?
Yes, I can see it.
Okay, I think I'll.
Okay. It's sideways on. I don't know how to rotate it. So, and it's very, very poor quality. So, and I don't know how to make it stop. So maybe it's not such a good idea. I'm not sure how helpful that's going to be if people can see that. It's really just a really great way of trying to get tendon gliding in later stages of rehab. And then if you don't have fancy thermoplastic and you want to make an early a motion splint of your own, pencils and elastic bands are a great way forward, I've found. And no excuse not to use pencils and elastic bands. Oh, that appears to be the same one. And just ideas for using everyday really light objects. That's maize, popcorn kernels, just to get fine motion dexterity, nice and early. And another one, a really good, very light early motion. So you're getting really good span, having to use everything really well there. Oh, okay. That was it. Those were the videos. So I hope they didn't disappoint. There were just supposed to be a couple of ideas of things that are really easy to do, end stage rehab.
No, they were very good and a really good point to finish on, I think. Once again, stressing the importance of rehabilitation. So I will draw things to a close because we are at about our advertised closing time. I think basic principles, you know, that old surgical principle of wanted to get the best possible result with the lowest risk of complications should guide our choices of management. That clearly is impacted on the resources we've got available. As surgeons and therapists, we should be aiming to continue to develop our skills and knowledge, and hopefully this has contributed to that. But equally important, I think, wherever we work, we should be spending time developing our referral networks and working with our populations and, most importantly, the doctors and patients present to initially with hand trauma, to ensure that they understand the importance of early referral to a hand surgeon. And then finally, that importance of rehabilitation. So I'd particularly want to thank all the panelists for their time and efforts this afternoon. Want to thank the participants. We've had over 100 people logged in, which is very encouraging. I want to take the opportunity to advertise the next one in this BSSH WACS series, which is on October 10th, and that's on soft tissue management of hand wounds. Flows very well on from fractures. Before then, there is a BFIRST BSSH part 2 of the congenital hand series on the 22nd of September, and the first session of that was very well attended and very well received. So again, details of both are on the BSSH website. So I look forward to seeing you all again, and thank you everyone for your attendance.
Thank you.
Bye.
Thank you. Bye.
Thank you. Bye.
Thank you.